I am pleased to announce or to introduce our speaker this morning, Dr. Matt DeCamp. For those of you who don't know Matt, Matt, are you coming up on your second year with us? Is that right?
In the middle of the second year.
Middle of the second year. So we recruited Matt from faculty at Hopkins. He started his academic career at Purdue as an undergraduate. He got his MD and PhD in philosophy at Duke. He did his house staff training in Michigan, health services research fellowship at Johns Hopkins, and then was on faculty there. And we were fortunate to recruit him. So Matt is part of our of the division. He practices at DIMG, and he is engaged in research. He is an empiric bioethicist and is a national thought leader in that area. And so we're delighted to have him, and delighted to have you giving grand rounds this morning. So thanks, Matt.
Great, thank you. I appreciate the opportunity. I know this is actually a bit of a change from what I was originally going to present about some of our research related to artificial intelligence and ethics, just because we thought there might be some interest in hearing a bit more about the ethical issues that are coming up in the response to COVID. I'll say at the outset that I'm okay if you interrupt me via the chat, or if you can by activating your microphone during the presentation. Also happy if you want to wait till the end and have questions then. So these are the simple objectives today. I hope that you'll be able to understand one area of consensus and one area of disagreement in some of the COVID-19 resource allocation plans. Matt Winia in our group has done a lot of work in this area. You may even have heard him present on this topic in other fora, and I'll summarize some of that and maybe give a couple different opinions that are out there about resource allocation. We'll talk also in a bit of depth about this concept of the duty to treat patients with, and I think maybe even more importantly or more interestingly, patients without COVID-19. And then we'll close by describing a couple issues that I think are likely to emerge as this pandemic perspective. So I want to start just by making some brief comments about ethics in general, kind of to get us all on the same page. These are the common principles of biomedical ethics. Most of us in physician training are exposed to these principles of respect for persons, beneficence, that is promoting well-being, or non-maleficence, avoiding harm, and justice in the course of our training. Justice, of course, comes in two flavors. One flavor is distributive, and it has to do with how we distribute things like organizational resources. Scarce organs is another common example used related to distributive justice. And there's also procedural justice, that is developing fair decision processes when there are issues on which we can't all agree. So these are the three basic principles of biomedical ethics. It maybe is worth pointing out that in the philosophical literature around these principles, the idea is actually that the three principles listed here are cross-cutting across all cultures, meaning that we see evidence of acceptance of and employment of using these principles to think through ethics problems, even if the way the principles look may be a little different. So we might say that in some cultures, respect for persons is less individualistic and more community-oriented. The people who started the thinking about these principles, at least, don't believe that that invalidates the principle of respect. They just mean that it looks different in slightly different contexts. Now, I introduced these principles just to get us on the same page, and also to introduce the idea that I see principles like these as lenses. That's why there's a little lens at the top of the slide. And the lens is meant to reflect the idea that we can use principles to help us understand problems in contemporary medical practice and health policy, and help us to analyze some of these issues. So I won't belabor the meaning and the different obligations that come from these principles, but I at least wanted to lay them out and get us on the same page. I noticed there is a question in the chat about topics the Center for Bioethics is working on. I do have a bit, if there's time, I do have a few comments on that at the end of the presentation. So don't let me forget that comment in the chat. All right, so another important point about ethics really is the distinction between facts and values and the role of ethics in navigating the terrain between facts and values. So facts obviously tell us what is the case about the world. They're descriptive. Values, on the other hand, tell us what should be the case. It's the world of oughts and shoulds and musts. Now, in my view, we need ethics to help us navigate these two distinct terrain, this area between facts and values. And let me illustrate that with an example. So we could say it's a fact that there is numerical inequality in certain patient outcomes. But that fact alone doesn't tell us very much. Instead, we need concepts from ethics to force us to ask questions like, well, which outcomes matter? Or who decides which outcomes matter? How much inequality matters, to get us as a bridge from these facts to the value statement that says this is an unfair inequity that requires action. And so that really is one of the key roles of ethics, is helping us understand how to make sense of facts and how to translate facts into values that guide action, the should, the oughts, the musts. Third point, ethics and the law are not the same. Seems pretty simple. This is a simple diagram to illustrate that laws and regulations we often think of as the floor, and ethics, on the other hand, is the ceiling. And that's meant to reflect the idea that oftentimes within the regulatory flexibilities, the rules and such that we have, there are many opportunities where ethics, where the language and concepts of ethics can actually help us inform policy and practice. Law and regulations are the floor, ethics is the ceiling, ethics is the ideal. Just to give you a preview of where we're headed with some of the issues we'll cover and not cover today related to COVID, I plan to cover the top 4, at least: triage planning, the duty to treat, as I mentioned, issues of equity during COVID, and what I see as the coming ethics of vaccination once a vaccine is available. Below, you can tell there are a lot of ethics issues we're not going to cover. The terrain around ethics in COVID-19 is vast: liberty rights, quarantine, data privacy. You've probably heard about cell phone data, contact tracing. Research ethics was presented by other members of our group just the other day, scope of practice, and so on. I'm going to try to focus on these top 4. I think they may be some of the more discussed issues around the pandemic. I'm going to frame these a little bit around issues that everyone is talking about, issues we should be talking about, and issues we will be talking about. So let's start with the issues that everyone, I think, is talking about. And the first one is the concept of triage planning. When it comes to triage planning, that is, how do we allocate resources when resources are scarce, whether it be ventilators or other things? This is obviously putting us in the terrain of justice of the distributive type. And work over the past decade, as you can imagine, following off the H1N1 pandemic in 2008, 2009, work over the past decade by the Institute of Medicine and the National Academies has been trying to clarify this concept of crisis standards of care. Crisis standards are defined as substantial changes in usual healthcare operations and the level of care it is possible to deliver, which is made necessary by a pervasive or catastrophic disaster. And examples, of course, including pandemics and so on. Crisis standards of care is a bit of a term of art. I see it as somewhat synonymous with triage planning, resource allocation. We'll talk more about that. But if you look at some of the principles that are emphasized as governing crisis standards of care, you can see that there's emphasis on a strong ethical grounding, emphasis on community and provider engagement in the planning process, and the legal authority from governments, which plays an important role in implementing crisis standards. Now, something you may not have heard much about is that crisis standards are not without their critics, particularly in the bioethics literature. Everyone accepts that there's a potential need to allocate resources fairly and shift more toward population-oriented outcomes in a pandemic, but some question this idea of whether we need to actually change the legal standard of care as being unnecessary, because legal liability is not a real concern during crises. That is, the concept of a standard itself can accommodate standards during emergencies. There need not be a change in the legal status. Second, a concern that changing standards creates disincentives, interestingly, to improve care during disasters. That is, if we're willing to accept a lower standard during a disaster, we may not have the incentive to actually improve care in the long run or over time. And also, changing the legal standard is risky because lowering the standard due to an external circumstance is a slippery slope. That is, it's going to promote us continuing to lower standards, all depending on how we define this notion of a crisis, right? So the idea here is that over time, we'll be sorely tempted to slowly change the way we define a crisis, and as such, allow lower standards to continually creep in to everyday medical practice. So crisis standards are not without their critics. I just wanted to make sure I spent a little time pointing that out. Back to something a little more concrete. Colorado, the state of Colorado does have a crisis standards of care plan. And here I'm going to illustrate one using ventilators as an example, probably the most common example people mentioned during COVID. Here again, when crisis standards are authorized by the governor, this is a specific authorization by the governor, and then enacted by a local chief medical officer, health system, hospital, and so on, they're meant to provide guidance and, as I mentioned, protection from liability for healthcare professionals operating in crises. And just so you know, in April 2020, and I think these are still active, the governor here did authorize crisis standards for both PPE and EMS providers. The standards I'm about to show you have not been enacted. This is what they look like in a snapshot. The idea is that if there's a situation where two patients are in equal need of something, say a ventilator, the decision-making process goes through these four tiers. In tier number one, there's an assessment of short-term survival plus near-term survival using the combination of the SOFA score and a modified Charleston comorbidity score. So the first attempt to break a tie between two patients is to use these two commonly used, accepted scoring systems in clinical practice. Now imagine those scores are tied after tier one. If that's the case, tier two brings up special preferences, tiebreakers, that is, that give preference to healthcare workers, preference to first responders, and preference to children. Now let's say we go further and suggest that there's still a tie after tier two. Now we move to tier three, and there's some additional special tiebreakers. These are given for pregnant women, for the number of life years saved, that is the number of life years left to live, and another special tiebreaker for sole caregivers or providers of families. Now, if we finally get to tier three and there's still a tie, we're still stuck between these two patients. We've not been able to break the tie of who gets the ventilator. We go to tier four, and then it's a lottery system. It's simple random allocation. That is a flip of a coin. So this is an example of the Colorado crisis standards of care. Now, many states are creating crisis standards. Many health systems are creating triage plans. Many of them look a lot like this one. There are major areas of consensus, I think, worth pointing out that are ethically relevant when it comes to crisis standards. One is that the decision frequently is made by a triage team, not bedside clinicians. So in ethics, there is this general prohibition against what's called bedside rationing. And so often triage plans, crisis standards plans involve a triage team to take decision-making away from bedside clinicians who may have biases, who may be less efficient in determining allocation, and so on. There is a lot of consensus around the notion of survival as the primary emphasis, the primary goal of a crisis standard or a triage plan. Hold on to that because we'll talk about the areas of disagreement related to survival. Most every plan at least states the importance of non-discrimination, not making decisions based on race, ethnicity, and so on. That said, we'll talk about the fact that some policies may inadvertently, in practice, exclude certain groups, but at least as a statement, non-discrimination is emphasized. Most plans also note concepts of procedural fairness. Remember that second flavor of justice, not just distributive justice, it's procedural fairness. And these include transparency about the plan. As I mentioned on the prior slide, you can go to the Colorado website and read about the crisis standards of care and see the plan online. That's an illustration of transparency. There also has to be accountability. That is, the people who make decisions, such as the triage teams, must be accountable for those decisions. Sometimes this requires very clear documentation of the process and how the decision was made. Sometimes plans also include limited appeals. Remember, I told you that triage teams, an express goal is to take decision-making away from a bedside clinician. Pluses and minuses to that. As a matter of procedural fairness, you can see the importance of allowing frontline clinicians, bedside clinicians, to be able to appeal a triage team's decision about resource allocation. And finally, support for the special moral distress that these decisions will cause. If you look in a lot of the literature that's come out of the New England Journal and JAMA, there's a clear recognition that clinicians, nurses, physicians, and others who will be involved in these decisions at the bedside, even when they're potentially made by a triage team, will experience a lot of moral distress. And this needs to be supported and recognized by the institutions where these individuals work. So those are the areas of consensus, but you should also know that there are plenty of areas of disagreement related to crisis standards. And I just want to, this table shows a few. I'm just going to highlight 3 of them. I already mentioned this first one, which is the disagreement that exists around maximizing lives saved versus life years saved. Simply put, a life years saved approach will always preference someone who's younger over someone that's older, and may also preference someone who, say, has a disability or has a chronic medical condition compared to someone even at the same age. So some ethicists and some groups believe that this life years saved approach should play no role in any sort of allocation. It may be okay if a SOFA score, for example, were to indirectly include age, or a comorbidity score were to indirectly include age, but as a simple judgment, age alone should not play a role. The best example of this is the American College of Physicians, which you may be interested to know believes that the current Colorado crisis standards violate the principle of non-discrimination as they've recently published it. There's also disagreement around whether healthcare workers deserve any sort of preference in plans. You can see that, as I mentioned, that's part of Tier 2 in the Colorado plan, but some people will counter-argue that healthcare workers are already privileged and so don't deserve additional preference when it comes to a triage scheme. And there's, quite frankly, a lot of disagreement about who counts as a healthcare worker. Is it physicians, nurses? Is it people who work in hospitals, and so on? Drawing that line between who counts as a healthcare worker turns out to be practically very problematic. Another area of disagreement, the third one here, withdrawal of ventilators. Permitted under the Colorado plan and was a flashpoint in the New York plan. To put it concretely, there was some concern, and there's debate over how real this concern was based on the language of the policy. The New York crisis standards would permit the following to happen. A patient who's chronically on a ventilator goes to the emergency room because of worsening respiratory distress or perhaps some other healthcare issue. There was concern that that patient's ventilator could, in effect, and become part of the ventilator resource pool that could then be used to help manage the crisis situation. So clearly a controversial issue when it comes to crisis standards. I want to take a moment and step back to that notion of facts values that I introduced earlier and the role of empirical assumptions when we evaluate ethical judgments. It's important to remember this distinction because facts can inform our ethics judgment and vice versa. So as I mentioned, it's not enough to simply state a value in a policy, such as a value about non-discrimination, if in fact the way the policy or protocol operates in practice seems to violate it. So that's something that's really important when we think about how we evaluate crisis standards or triage plans. Another example, arguments in favor of giving this special priority to healthcare workers often rely on empirical assumptions, not just ethics. So, for example, if we think we need to give priority to healthcare workers because otherwise they won't come to work, this is actually a question of fact. And we have to ask ourselves, is it actually true that they don't show up at work? Or is it such a small number that don't show up to work that it's not even significant? Or should we give, if we say we have to give priority because they'll go back to work later to save others, well, this is another question of fact because it depends upon the nature of disease, how long someone is out of healthcare, how many do come back, and what sort of services do they provide. So this is an important illustration of this intersection between us needing facts, which we can investigate empirically, and the questions of value that we're struggling with around crisis standards. So to be concrete with the Colorado standards, we could imagine the following two patients. Patient A is a 45-year-old, no chronic conditions. Patient B may have the same likelihood of survival in the short term, according to something like the SOFA score, but is 59 and has evidence of cognitive impairment. If we rolled through that Colorado crisis standards of care, we would see more than likely that patient A gets the ventilator with an equal SOFA score, but greater comorbidities such as age or potentially dementia. And there I'll point out that a lot probably depends on how we define dementia. But some would say that this decision actually violates notions of fairness. So when I presented this scenario to the ECHO Colorado participants, this is a group of primary care providers all across the state of Colorado, 57% said A should get the ventilator. Common intuition, I think, the younger patient is healthier. But 11% said B, and 31% said flip a coin. So an illustration, I think, of the potential tensions or disagreements that exist even within our currently accepted Colorado crisis standards. I mentioned at the outset this concept of procedural fairness, including engagement within the crisis standards and in the Institute of Medicine report. Engagement is a key ingredient in the ethics of triage planning, yet there does seem to be work still need to be done. When I asked that same group of ECHO Colorado participants this question, when patients are admitted to the hospital, how much do you trust that they'll be treated fairly? Only about 1 in 5 trusted they'd be trusted completely, they'll be treated fairly. A significantly higher number said they'd trust some, but you can see a lot of people uncertain about whether their patients would be treated fairly, and some people not at all trustworthy of what would happen during scarce resources. So evidence, I think, that there's a need for engagement of the provider community to help understand and get perspectives on crisis standards. All right, so that's the first issue that everyone's talking about, crisis standards. Hopefully have some discussion about that at the end of the presentation. I want to move to the second issue that everyone is talking about, and that's this concept of the duty to treat. If we look historically, the duty to treat has had a bit of a roller coaster. It's part of the duty to care in some approaches to ethics, but if you look back to, say, the bubonic plague in the 14th century, the mantra among physicians was to flee early, flee far, and return late. Clearly not much of a duty to treat in that time. Then in the 19th century, the AMA Code of Ethics emphasized that physicians should provide care even at the jeopardy of their own lives. And in fact, in the 1918 Spanish influenza, there was significant evidence of physicians seemingly accepting or endorsing such a duty, acts of heroism, and so on. Then in 1957, the AMA Code shifts its language a little bit and suggests that physicians have a duty to treat to the best of their ability, so not clearly saying anything about risk. In 1977, the code is silent. And then 1980s, HIV happened. The epidemic here renewed a lot of attention to the concept of the duty to treat, largely around controversial decisions by physicians and surgeons who elected not to treat patients who were infected with HIV. This created a lot of debate around this duty I think in general shifted us more toward the acceptance or the existence of such a duty, such that in 2016, the AMA suggested that the duty to treat holds even in greater than usual risk. Now, anyone who's carefully looking at that statement will, of course, note, what counts as greater than usual? That seems like a bit of a fuzzy definition that requires a bit more elaboration. But just to give you a sense of how this duty has over time come and gone, and now perhaps more widely accepted. Now, ethics doesn't just stop at the acceptance of a duty, that it exists or that we believe it exists. Ethics will ask, what's the justification? Where does the duty come from? Duties don't come out of thin air. So where do these things come from? And so in this table, I've shown just a lot of attempts of justifications for a duty to treat. So you can see at the top the idea of consent. If you sign up to be a member of the medical profession, you've accepted the duty. Even if you haven't explicitly signed a contract saying that there's a duty, you may have implied consent around the duty because you probably should have known it existed, and so therefore you have it. A second justification relates to the special capacity or capability of physicians, and that is because you or you alone have this capacity to treat people during times of pandemics, illnesses, disasters, and so on. You have the duty. Because you have the capacity, you have the duty. A third common one, reciprocity. As part of medicine's social contract with society, the benefits that the professions have within society are given in exchange for its members having accepted this duty. Some might say that the presence of the duty within oaths and codes, like I mentioned back here in this AMA code, emphasizing it in 2016, the fact that it exists in an oath or a code means that it does exist by profession, by literally professing that duty. Others might suggest that the duty to treat people who are infected is really a simple application of the duty to care. That is, the regular duty to care applies. Medicine is always risky, always has been risky. It may even be less risky now than it used to be, now that we have PPE and other forms of protection. And so it's a simple application of the duty to care, that we have a duty to treat people even when it comes at risk to ourselves. And then finally, the virtues of being clinician, a sixth approach, emphasizing that caring is simply part of integrity, individual integrity to the moral enterprise of medicine. So a lot of philosophical wrangling around where this duty comes from. And just so you know, no clear consensus about where or which one of these is right. Perhaps you have thoughts about it, but I just wanted to illustrate the attempts within bioethics, at least, to try to justify duties that are given or expected to be fulfilled by physicians. There is evidence empirically that physicians and other healthcare professionals endorse this duty. Again, I'll go back to that Echo Colorado presentation from a couple of weeks ago. We asked about agreement with this statement. Healthcare professionals are obligated to treat COVID positive patients, even when doing so carries personal risk. About 100 people in that webinar. You can see that 81% or so agree or strongly agree with that statement. On the right, a similar survey done in the United Kingdom 10 years ago, again, following on H1N1, you can see again, more than 2/3 people agreeing with the statement that doctors and nurses have a duty to the sick despite risk to themselves. So empirical evidence that healthcare professionals accept that there may be such a duty. So it seems to be the case that most people accept it, but of course you can imagine the devil is in the details, and there are real questions about how much risk is reasonable. Is the duty that, when we say duty to treat, is it limited or is it broad? That is it limited to your scope of practice? Or is it broad in the sense that all physicians and healthcare professionals have a duty to step up? That is, does the duty to treat mean that there's an all hands on deck moment that we all should be hopping on planes and flying to New York City as part of this particular duty to treat? It's worth pointing out that assigning this duty doesn't occur in a vacuum. So there's a lot of rich scholarship around what healthcare organizations or society may owe to physicians and healthcare professionals because of the duty. Is it about maximizing protection for health workers, giving them extra support, or as we've already talked about, perhaps giving them preference in triage schemes? There's a question in the chat about the duty of individuals to treat despite risks when there's lack of PPE. I think that actually comes up in this particular case here, which is an implication of what we're talking about to the COVID positive patient. And that is to say there's controversy around this duty and, for example, CPR for COVID positive patients. So a recent framework published in the New England Journal suggests that we should acknowledge resource constraints when discussing DNR status in the setting of COVID. We should forego CPR entirely when necessary, such as when there are no ICU beds or when it's the result of a triage plan. And we should forego CPR if the chance of benefit is small compared to a large risk to the healthcare team. But others offer caution, suggesting that discussing resources could be coercive or be applied unequally, and that even in standard times, ICU beds are often unavailable, so to speak, and yet we still resuscitate. We still resuscitate patients with influenza. And some will say the question is whether the patient can benefit or not. It's no different here. And there's a risk of tipping the scale too far towards protectionism, protecting our own risks. So there's no easy answer to the question in the chat about lack of PPE, right? I mean, most of us would say there's a clear obligation on the part of institutions and organizations to provide, to the best of their ability, PPE. And in fact, if it were provided, this could be a very much moot point. On the other hand, it's hard not to acknowledge or recognize the fact that frontline clinicians may be faced with situations where there is limited or inadequate PPE, and the risk is increased to the healthcare team as a result. And what do you do? That's the question. And so one of the things that ethics works on is how do we think about tipping that scale? Where should the balance be? Physicians and other healthcare professionals are not expected to take on infinite risk. They're not expected to be martyrs, even under the duty to treat. But finding that line between how much risk is acceptable is a really challenging question. And in fact, there may be no answer. There may be no bright line about that. I said I wanted to expand the duty to treat to think a little bit about COVID negative patients and to suggest that we have to also be careful about tipping the scale towards protectionism when it comes to risks and benefits for non-COVID patients. So some real examples that have come out of Echo, Colorado, and discussions I've had with colleagues. A middle-aged patient with diabetes and hypertension calls their clinic because of nausea and vomiting. Usually would be seen, but in this case, it's attributed to gastroenteritis. They're treated symptomatically, and the patient later suffers an MI. 70-year-old with severe emphysema is discharged home earlier than ordinarily would be considered safe because of concerns of coronavirus exposure in the hospital. So tipping the balance, tipping the scale a little bit of our decision-making. Or a Spanish-speaking patient is offered a telephone-only visit because video translation is not yet available on virtual visit platforms. So implications, I think, of the duty to treat, the duty to care, affecting non-COVID patients. And you can see on the bottom, this has been written about in the New England Journal as well as the New York Times. Some concern, in fact, that data are suggesting increased mortality from stroke and other non-COVID illnesses during the COVID pandemic. I'm going to skip this. I mentioned the usual discharge, but to give us a little more time for discussion, I'm just going to skip this slide that highlights a couple of the ethics issues unique to early discharge. So third, I think an issue we should be talking more about. People are starting to talk about this, but I think we should be talking a bit more about it. And that's the issue of health equity. So if you look at some of the data, which have been published in the Washington Post, plenty of other places, it is now painfully and obviously clear that African Americans are suffering a disproportionate burden of COVID illness and COVID deaths. So in one study within 131 Black counties, the infection rate is 3 times higher than whites, and the death rate is 6 times higher than whites. So clear issues of health equity emerging from this pandemic. From the standpoint of ethics, I've been pondering this and thinking a lot about whether these big things have small beginnings. That is, how do our micro allocation decisions end up with macro effects? And I think about the emphasis that I've already placed in this presentation on the crisis standards and ventilator triage and so on. But I worry that by the time a patient gets to the point of needing a ventilator or nearing death from COVID, imagine all the micro decisions that have affected the person's likelihood of benefiting from that ventilator or from that intervention at that point. Access to protective equipment, the type of work the individual does, whether they had equal access to testing, and all of these decisions, how do they build up to create a situation where by the time that person gets to the decision we're focused on about ventilator or not, it ends up being virtually guaranteed that they won't receive it, they won't benefit, they'll be more likely to suffer the effects of the illness. So I think it's worth thinking about how some of these small, what I would call everyday decisions, or even everyday rationing decisions, how we ration or decide about testing in the clinic and so on, can add up to contribute to that situation of equity I just described. We are in a funny position when it comes to this pandemic, which is this famous curve about flattening the curve. If we think about it from the standpoint of equity and the effect over time, we could imagine that we're in this unenviable position where if we achieve our goal, if we achieve the goal of flattening this curve over time, it's actually likely to increase the disparate impact on health and other social determinants for vulnerable and marginalized groups. That is, the people and individuals who have less reserve, less resilience in economic times, are more likely to suffer and to continue to suffer over time. And this is issues of work, play, and health. If we achieve our goals, we're going to see these disparate outcomes. Here's a short side note, maybe of trivia interest. We're all talking about social distancing. I think we all know what we mean by it, but we may have actually misappropriated the term. If you look back into the early 20th century, social distance was originally a psychosocial concept meant to evaluate people's willingness to be around ethnic groups. So a true social distance rather than what we may actually be talking about, which is physical distance. To illustrate this somewhat humorously, here's an example of one of the social distance scales and the questions that are used. It's to select the option that best describes your feeling towards a group of magicians on the basis of the following statements. Would you be willing to marry a member of the group? Would you be willing to have a member of this group as your close personal friend, and so on? This is actually the original concept of social distance. It's perhaps just of intellectual interest that it's been changed and morphed into the definition as we know it today. What do we do about equity? We all recognize that there are these stark differences as a result of disparities now and in the past, but what do we do about them? On the one hand, you'll hear statements like this: during the battle against the virus, using a wartime analogy there, probably purposely, the pandemic is not the time for remediating disparities. The other ethics approach would say, if not now, then when? Those of you who know about human rights may understand this as a quote from the late Jonathan Mann, who was active in physicians and human rights, begging for the interaction between medicine, public health, and human rights, and asking, if not now, then when? I think we simply at the outset have to acknowledge that a purely greatest good for the greatest number approach, a utilitarian approach, a maximizing lives saved approach, is by definition distributionally insensitive. It does not care whose lives are saved. Some have argued for preferential treatment of certain groups, despite a reduction in lives saved, that is giving special preference to vulnerable or marginalized groups who have experienced disparities over time, but this is not the dominant view. In general, I would say people are more on the left box, that is checking the concern for equity and disparities at the door, even if we all acknowledge it's important to reveal them and make them known over time. I'm going to close with just a couple brief comments about issues we'll soon be talking about, and then hopefully have time for discussion or within the chat. I telegraphed this earlier by mentioning the ethics of access to vaccines. Here's an article in the popular press. Let's say there's a COVID-19 vaccine. Well, who's going to get it first? This is something that a lot of us may have faced, or at least I remember facing during H1N1 when I was at the University of Michigan. I seem to recall, if my memory is correct, that healthcare workers and pregnant women were first in line for the vaccine as it rolled out. Not sure that's going to be the correct approach for COVID-19. So which approach to justice should decide vaccine allocation? Is it most at risk? And if it's most at risk, is it the risk of getting the disease or of having a complication from the disease? Those could be different. People may be at risk of getting the disease, but not be at risk of having the complication. Should essential workers be given the vaccine first? And if so, how will we define essential? Will healthcare workers be essential, restaurant, businesses, and so on? Or should we be thinking about who would be most likely to benefit from the vaccine? If we think that individuals who are older are less likely to mount a response, as we've seen with other vaccines, should we preference younger people when it comes to vaccines? So I think the next issue people will be talking about is access to vaccines. I see there's a comment in the chat actually about the if not now, then when is attributable to Hillel the Elder. Oh, that's interesting. I'll look that up. Maybe Jonathan Mann appropriated it and didn't cite it. Thanks for that comment. There's a second issue that's come up in the literature, and that's this concept of immunity passports. So some have suggested that immunity passports, as a result of a positive COVID antibody test, will be permitted, maybe required, for work, travel, and other activities. Now, we know that evidence is lacking about the current antibodies, but what are the ethics as we think through this? Might we create a new social divide? That is, those who have immunity and those who do not. And we can all imagine who might be within the different groups of that divide. Could this result in coercing people to get tested to prove that they have immunity? Or might it also coerce people to do things after they are tested? Meaning if you test positive, you have the antibody, are you therefore required to go to work when someone else whose test is negative need not go to work? And then perhaps unintended consequence of an immunity passport or license could be that we're incentivizing people to get infected or to falsify their test. Will there be chickenpox parties in the COVID era where instead it's parties set to get people exposed to coronavirus so that they can then test positive so that they then get their immunity passport? Kind of an interesting issue to think about. The World Health Organization has discussed it, as has a recent commentary or viewpoint in JAMA. Lastly, third issue I think we'll be eventually talking about is the concept of global health equity during COVID-19. So we've seen reports that countries like ours are buying up medical supplies, PPE, and so on, leaving poor countries stranded. A collaborator in Guatemala has discussed the need to put both influenza and possible coronavirus patients all in the same ward, only because they can't test to differentiate the two. There's a lot of debate now in policies at the global level around patents and monopolies on potential coronavirus treatments, controversy over remdesivir, which you probably heard about, initially being given orphan drug status, where the company explicitly applied for orphan drug status while the case number was still below 200,000 to get special intellectual property protections, fights by other governments around the world to try to do what's known as compulsory licensing of the drug so that they can produce it on their own, even if it is not patented, to help ensure that the treatments and medical interventions that come from research and development on COVID-19 benefit all globally and are not sort of gobbled up by the rich countries of the world. And that applies to all things, whether it be drugs, tests, or vaccines, as I just mentioned. So we're right at 8:45 and just close with a couple conclusions. These issues that I've described around COVID-19 are not necessarily unique. Many of them are old questions that we faced before. We faced them in prior pandemics. We faced them in other circumstances, even around everyday clinical practice. But clearly, some of them are a bit new. It's hard to deny that the impact of coronavirus on standard healthcare operations is widely more than any of the recent pandemics any of us have experienced, whether it's H1N1, SARS, and so on. So a lot of issues, we've discussed only 3 or 4 of them, hopefully giving you a sense of where the ethics landscape is around them. This next point just comes back to the chat, which is the question of what we do at the Center for Bioethics. I'm not going to be able to summarize what everyone does, but I've purposely implied throughout the presentation this critical need for both empirical and conceptual bioethics. That is, this interaction between facts, the empirical, and values and how they interplay, which is exactly what most of us at the Center for Bioethics are doing in our daily lives. That's what we do when we write grants. That's what we do when we write papers. We're trying to understand this interplay of empirical and conceptual bioethics across not only COVID-19, but artificial intelligence, conflicts of interest, sports medicine, brain injury, and so on. So that's a bit of what we do. And I think that this presentation was meant to illustrate that. As an example, as I close, one thing we've considered doing as a research project relates to these triage protocols I mentioned. We don't all agree on what the precise goal of triage should be: lives saved, life years saved, and so on. We actually don't really know which of the possible triage protocols best achieve this goal. And so we've considered at the center doing a grant where we model different triage plans and protocols. Do you give preference to healthcare workers or not? Do you give preference to age or not? And simulation modeling out what the effects of that would be at the health system level. Again, as an example of using an empirical, testable hypothesis to illuminate what are fundamentally questions of value or ethics related to triage planning. So I'll stop there. I'm happy to start taking questions in the chat. Also happy if people unmute and want to have more of a discussion. Thanks for listening.
Matt, thanks so much for that terrific talk. There are a number of questions in the chat. I don't know if you want to just take a peek at them and similarly invite people to unmute and ask their questions.
I think if I remember, there was a question about, oh yeah, so what are the ethics about discussing this when we don't know yet about antibodies? I think that's probably a question related to these immunity passports. And that's exactly what the World Health Organization says. The World Health Organization says, look, we shouldn't really be talking about passports, or at least immunity passports or licenses should not be permitted simply because there's no evidence of what antibody tests even mean. A very reasonable position. Those of us in ethics will emphasize, however, that we need to be thinking about the ethics now, because remember that fact value distinction. If we allow our argument against immunity passports to rest solely on the fact of the matter that the current tests don't work, we could be blindsided in a few months when the evidence comes out that the tests are accurate, they do mean what they think they mean, and we haven't thought through the ethics of what they would mean in practice. So totally agree. As a factual matter, it's a bit of a moot point at the moment. We still need to think about the ethics. Let me see. I'm reading stuff.
Sami Diab here. Can I ask a question?
Sure.
Yeah, good morning. Great presentation. Thank you so much. I'm a medical oncologist in the community, and I was wondering, I mean, there's so many different opinions about how do you apply these ethics value based on background, based on maybe political views, spiritual views. And so is the goal of ethics to help make these decisions, or is it just a room for debate? I mean, how can we use ethics really to make decisions? And should there be like a national standard of care for ethics that's not very controversial? Because it seems to me like, you know, you can interpret any decision and put an ethical value on it that would fit a certain position that you'd like to take.
Yeah, great question. I think there are a couple ways to answer that or think about it. You know, many times in ethics we might say there's no single right answer, but most of us would all agree that there are certainly better and worse answers, and there are certainly better and worse justifications for answers. So I can perfectly acknowledge that there may be no right answer, but certainly some answers are better than others. That's one thought. The second thought is it's clearly true that good ethics requires good facts. that's why I emphasize that point about if you use a justification for preferencing healthcare workers, that's the only way you're going to get healthcare workers to show up on the job. Well, if that's your justification and it turns out that it's not empirically true, it's not much of an ethics justification. And so we can fetter out parts of arguments by understanding that interplay between facts and values. The third response, I would say, is that many folks will emphasize that if we get to these points where we can't all agree, that's where the procedural aspects of decision making are simply really important. When we understand who's been involved in the decision, is the decision transparent, are there accountability measures for a particular action taken, are there appeals mechanisms for changing the decision over time as new facts or new values come about. So some people will rest squarely on those procedural elements to help make a concrete decision in practice. So I fully acknowledge the point, and I'll underscore it by saying that those principles of biomedical ethics I started with are not universally accepted. But I think the task of ethics is really much more in the realm of better or worse decisions, better or worse courses of actions, rather than saying there's one single right.
Great, thank you.
I want to sort of combine a couple of questions on there. So there are a few questions in the chat about other ways in which our standard of care have changed. So, for example, we're treating people at home that we might otherwise treat in the hospital, or by video where we might treat face-to-face. And two questions related to that. One, in fact, that people are protected from iatrogenic harm, and that there may be some benefit to that. The second, a question about what are we doing to actually try to understand this and the impact. So any thoughts you have on those?
Yeah, sure. The second question may be easier. It's clear to me that this issue of non-COVID morbidity, mortality is an active area of research. So people are monitoring for this. There's no doubt. The Agency for Healthcare Research and Quality call for COVID-related grants actually explicitly calls it out as a topic of interest. So there will be people and are people who are monitoring this in non-COVID morbidity, mortality over time. As for the risks and the benefits, it's clear that the risk-benefit calculation is different, right? Like, I don't want to imply that we're saying that everyone needs to have care as usual. On the one hand, it seems to me that we're always engaging in this kind of careful risk-benefit balancing, right? Anytime a patient calls the clinic and then I interchange with them by telephone, even under usual circumstances, I'm trying to figure out, do they need to come in or not? Do they need to go to the emergency room or not? So in some ways, we're always doing that. On the other hand, I think what people are concerned about from the standpoint of ethics are two things. One is that fear and paranoia around COVID-19 tips the scale too far toward protection of ourselves. Maybe that's because we don't have adequate PPE or other adequate measures for protecting ourselves always available to us. But there's a fear that it's tipped the scale too far, that now we're saying we're not going to accept any risk. That's why I kind of tried to slip in the issue of performing CPR on an influenza positive patient. I understand influenza is different. It's a different illness. It's clearly different across the community. But this issue of tipping the scale is what a lot of people are concerned about. And the second part of that I didn't discuss concerning ethically is that when we apply the duty to treat in this way, that's more protectionistic, it tends to systematically disadvantage certain patient groups. That is, in the HIV epidemic, if you remember, the duty to treat by physicians refusing to treat ended up having disparate impact on certain vulnerable and marginalized groups. So that's a case where there's intersection between obligations of beneficence or caring or duty to treat and obligations related to justice, because the actions we take end up affecting different people differently. So, again, the ethics of this and the risk benefits, very complex, I think need to be thought out and thought about. The concern being more toward, are we being overly protectionistic? Let's see.
Matt, can I ask?
Sure. Hi, Matt.
So that was an amazing, really nice talk. You covered an enormous amount of ground, so I feel a little guilty asking you to cover even more ground, but I'm wondering if you have reflections on the current discussions around allocation of remdesivir. As you undoubtedly know, the initial sort of batch of remdesivir was sent to a few hospitals, and it wasn't entirely clear how the feds made the decision which hospitals were going to get it. Now they're sending remdesivir in batches to the State Department of Public Health, which is then distributing it to hospitals on the basis of the volume of COVID cases they're seeing. But we have not yet provided guidance across the state to hospitals about how to use the allocations that they're getting. And at the moment, it looks like we've got probably enough to treat all the people who really might benefit, and we have very little information about who benefits.
Mm-hmm.
But really interesting sort of conversation, very similar to the conversation around ventilators, about whether there should be some level of prioritization given to communities that are especially hard hit by the COVID virus. And specifically saying, for example, that you should set aside some of this to give to people who are on the front lines, or to people from meatpacking plants, people from nursing homes, places that are really getting hit hard. And I wonder if you have any thoughts on that sort of targeting of remdesivir, not so much on the basis of the individual's likelihood of benefit, but on the likelihood that it might provide benefit to a community that is being particularly hard hit.
Yeah, that is a great question. And to follow with I haven't followed this closely, but to follow your question with the question, is there any requirement in the distribution that data be collected and that research be done, or that it be done in a certain format, or is it, you're shaking your head, huh?
No, I mean, there's very little guidance. There's essentially no guidance coming from the federal government. There's batches, and of course we don't even know when we're going to get the next batch.
Well, I guess I just have two thoughts. The first is, it strikes me this is a case where preference. I didn't talk about preference to people who have participated in research as one of the areas of disagreement within triage plans. But when it's something that's not, fully proven, or there's uncertainty, I think there's a much stronger case to be made for ensuring that data are collected, or that it's done in some kind of a more research-oriented format. The second point that your question, I think, so nicely illustrates is related to Michael Walzer's spheres of justice. The details don't really matter, but it's the idea that particular resources have particular contextual meanings. And the principles we apply to distribute one resource, like a ventilator, may not necessarily apply to another resource, like a drug, which exists in a very different context. And so I think there's a clear theoretical rationale for distributing remdesivir differently. And if I were to tip my hat as to where I think on some of these issues, I think there should be a whole lot more attention towards equity in some of the ways we're allocating resources. So I think there is a case to be made for distributing it on the basis of community benefit in the ways you've just described. I guess the problem is always going to be that if we do that, we have to accept some reduction in potential efficiency of treatment, right? That it could be that by doing that, it's not the most efficient use of the resource, depending, of course, on how we define efficiency. I don't know. Those are just two thoughts. I definitely don't have an answer to that question. Is there anything else here in the chat, or are we at time?
We are at time, and I think you've answered all the questions, I believe, in the chat. Well, let me again say thanks, Matt, for a very thoughtful and provocative presentation. a very timely one as well. So thanks everybody for tuning in to Grand Rounds and for participating. Thanks for all you all are doing out there to care for our patients and each other. And again, just a reminder, we will have a town hall meeting tomorrow evening at 7:30 with updates from the division.
Thank you.